So now we move on to the next talk by Dr. Leela Baid.
Thank you so much, organizing team, for giving me the opportunity today to speak here. My topic is something different from what we have been listening for so long. It's not CKM or it's not the liver and heart and all. It's the diabetes control. And in type 1 diabetes, it's very difficult to become to control the diabetes first of all. Because if diabetes is not controlled, we are leading the patients to complications. So the role of technology in diabetes management, automated insulin pump therapy. That's not going next. Yes, okay. Next slide. Okay. So blood glucose variables each day and night, insulin needs varies. Actually, there are 42 factors which affects the blood glucose levels in the body. And depending on day, night, stress factor, food, activities, there are so many factors. So there are a total of 42 factors. So what happens when the sugars are high, we advise the patient to take correction boluses, and administer the right amount of boluses is very difficult. So 1 out of 3 patients have high glucose episodes, and that are not followed by correction boluses, proper boluses. And 1 out of 2 times correction boluses are wrongly calculated, managing hyperglycemia. So whenever sugars are high, patients should inject an extra amount of insulin, which is mostly wrongly calculated. And if the patient calculates more, sometimes it is more calculated, over calculated, then it may lead to hypoglycemia. And if it is less calculated, it may lead to hyperglycemia. Carb counting is another one important thing, and it becomes very difficult in our setup, where there are so many varieties of food. It's not like food markings are there, nutritional facts are written in each and every food, going from your puri bhaji or samosa, or it's very difficult to calculate your carbs in the food. So calculating is very difficult. So nearly 50% of people with type 1 diabetes consider calculating carbohydrate as a burdensome aspect of diabetes self-care, and almost 59% of people with type 1 diabetes do not calculate the meal carbohydrate correctly. Leave about type 1 diabetes for everyone. Even most of our doctors also, it's not very easy to calculate, because the quantity, the amount of food and being prepared, it is different in each place, and it is different in each home itself. So what happens? Underestimation of carbs, again overestimation of carbs can happen. So for better glycemic control, results from closer monitoring and data-driven actions. When we can control the sugars and how we can control the sugars, it is most important is monitoring, and the second is give the insulin doses correctly. So monitoring is the first important thing. There are studies which shows that with SMBG, if you want a target HbA1c of below 7%, you should have at least 10 SMBGs per day. Most of the patients don't even do 1 or 2 SMBGs per day. And if you are on a glucose monitor like CGM, then you should at least do 22 scans per day to get an HbA1c of below 7 and keep your time in range more than 70%. What is the next step? Take action accordingly. Once the one is to monitor, second is to take action accordingly. So when we check sugar, we come to know that sugars are high or low, and accordingly inject. So more daily injections lead to better glycemic control. So there are studies which shows that if we use conventional 1 or 2 times of insulin, like premix insulin or a basal insulin, it leads to an HbA1c of nearly 9%. And if the injections are increased, like 4 to 5 times of injections, like 3 boluses and basal insulin, that gives an HbA1c of near 7%. So despite substantial increase in CGMS use, our HbA1c is still not improved in the last 8 years. It's written, it's like nearly more than 10 to 12 years. So the thing is, each years, the usage of CGM has increased, but the HbA1c has not reached the target. So why this is happening? Because we are not injecting properly. So only 21% of adults achieve the recommended HbA1c goal of 7%, and only 15% of patients achieve the HbA1c goal below 7%. And why it is not easy to reach? Because our scanning or checking the sugars and taking the injections. So here comes the importance of AI and automated insulin thing. I'm going to talk about the insulin pump therapy. So why pump? We'll discuss about this slowly. So there are different types of pump which were there in the marketed initially, and now latest we have come into the advanced hybrid closed loop pump. And what exactly it is? It automatically determines the blood glucose, like the blood insulin level, infusion rate all throughout the day, and also it with user initiated meal boluses, like patient has to just calculate on estimated bolus dose, and then if the sugars are high or low, accordingly the pump will adjust and give the basal accordingly. So with automated correction boluses also and basal also, it can lead to a improved TIR, and time spent in auto mode is much more good. So these are the this is the improvement in the pump therapy from first sensor augmented, then it was threshold suspend, then predictive suspense. What does threshold suspend means? Like when the blood sugar is reached to target, it will stop giving the basal therapy of the insulin. Similarly, first predictive suspend, which means that the latest pump were in 2015 the Minimed to 640 pump and all, those pump they could predict the hypoglycemia and they could stop the insulin secretion. Similarly, with automation, we have now reached to 780G, where a sensor is being used and continuously the glucose is being monitored, and then it has come into a automatic meal handling also. So right now we are in the 780G advanced closed loop pump. So this is Minimed 780G pump, and who are the ideal patient for pump? It's not that every patient needs pump. There are patients who needs pump. So who are the ideal patient? First of all, we should see that the carb counting patient can do approximate. It's not that they should do 100% calculation. It's an approximate carb counting they can do. Adhere to the diabetes management task. Are technically capable because they are machines and they should know when the machine is working and when the machine is not working. So definitely they should learn a bit of technology and prove that they are ready for doing all these things, and they will be keeping the doctor in the loop. They will keep the blood sugar under good control. And what are the other kind of patients? We can if the patients are not falling into criteria, we can still give them pump with a bit more of training. Later on we can consider them for pump. So what it does, this sensor augmented pump, it checks blood sugars 288 readings per day, and it gives frequent adjustments in the insulin basals actually. What are the parts of this pump? One is the Guardian Link 3. It's a transmitter and it is attached on the one side of the abdomen, and it is connected to the insulin pump Minimed 780G, and then the sensor will sense the glucose and it will give the information to the pump. And what pump will do is, it is connected to a smartphone app, and then it will it is also connected, it can be connected to your computer via USB, and all these things are also can be connected to your care link person. Like a child is having an insulin pump, if the parents are the care link, then they will also get sensor readings, and they will also get the hypoglycemia or hyperglycemia indications. And even a doctor can also be connected, like a care link connect app is there. With that, doctor can also see the readings and the results of the patient. So for the patient, they will need a pump, a mobile app, and the CGM. These three things the patient will need. The mobile will continuously show the glucose readings also, and we can keep the alarms based on their requirements. Like there are some basal setups, there are some bolus setups, range are there, how much postprandial you want and how much fasting you want. So these targets can be set for patients, and these patients are then connected into care partners like their parents or their caregivers. So what are the limitations for this, and what are the for whom we can use it? So for the management of type 1 diabetes is the best actually. Even type 2 patients also we can use, where the insulin requirements are it's not easy to calculate, and patients are only on insulin for some or the other reasons. And age below 7 years and older should be given, and total insulin dose should be 8 units to 250 units. Patient having too much of high insulin requirement cannot be put into the automated system, because if the insulin requirement goes more than 250, the automated system doesn't work actually. So the requirement of the insulin should be minimum 8 units and maximum 250 units. Not to be studied, it's not been studied in pregnant women, and also with type 2 diabetes, normally type 2 diabetes with OADs, because it may interfere with the action of the pump. So it's not being usually we given with the with tablets and this thing, because it might affect the glucose readings actually day to day, and also patient taking other medicines. Again, the manual mode is there. Every patient must start on the manual mode. So whenever we are starting the patient in an automated thing, AI doesn't work immediately. A 48 hours of manual therapy has to be given. The patient has to be admitted in the hospital, or better to give them under care. And we adjust the insulin dose from our side first initially. So requires an 48 hours, and we adjust the dosage, and then after 48 hours the pump picks up, AI picks up, and whatever dosage we have given in the last 2 days, it will try to calculate, and it will start giving the boluses and the basal by itself. So when we are using CGM, two automated suspend features are always available: suspend on low or suspend before low. If your patient is high risk, we can give and set a setting where suspend before low. We can give an indication that the pump will stop giving insulin even if the patient is not going into before low sugars happens. And auto basals are there. If the sugars are high, pump will give insulin every 5 minutes until the blood sugars are within the target range. So what are the target range? It's already given. And what patient has to do is, patient has to just do,
can you summarize it,
just a minute, last finish. So patient has to just enter the cart and bolus before the entering the thing, and then it will take care by itself. So I'll not go into all this thing. I also had the pump with me, but I'm unable to show that. It's okay. I have the pump with me. If anyone wants to see the pump, I can show them. Okay. Thank you so much. I'll just close the thing.